Welcome to the October Rapid Update in Therapeutic News. I'm going to give a quick overview of two NICE guidelines updated in September. Firstly, chronic heart failure in adults, and then the new pneumonia diagnosis and management guidelines. Both of these conditions are really important causes of illness and hospital admissions. So starting first with the chronic heart failure guideline. So the diagnosis recs are very similar to before. We need to do the usual GP investigations to explore the differential diagnosis, including an ECG and BNP. And when we're interpreting the BNP, nice reminders to be aware that it can be reduced by things such as obesity, ethnicity, and certain medications, and some conditions will also increase BNP. So the specialist assessment and echo will assess the severity and any underlying or correctable causes. And when that echo results comes back to us, it's important that we document and code the type of heart failure because that will affect our management. So somebody with a heart failure with reduced ejection fraction, so that's less than 40%, there's a strong recommendation to offer the 4 pillars of treatment. So an ACE inhibitor, a beta blocker, MRA such as spironolactone, and an SGLT2. There is a proviso here that to take into account the person's individual comorbidities and context. And the green boxes here remind us to consider the EGFR, and if it's less than 45, to consider starting at lower doses and use smaller increments. That dosing advice for people with CKD applies to patients, heart failure patients in all settings and all stages of the care pathway. And similarly, we need to be titrating the diuretics so that people get the lowest effective dose to relieve their congestion. And education and rehab are really important for people with chronic heart failure. It can empower them to self-manage and know when to call for help. The guideline visual summaries and on the NICE website are split into heart failure with preserved and reduced ejection fraction and mildly reduced, and those charts provide a very clear summary. So people with preserved ejection fraction, that's more than 50%, the treatment options are much more limited. You're not looking at those beta blockers and ACE inhibitors purely for treating the heart failure. And that's a really important consideration if you've got somebody who's got low blood pressure and you need to deprescribe. So the advice is to consider a MRA like spironolactone and an SGLT2 inhibitor, but again, taking into account the person's context and comorbidity. This is a weaker recommendation from NICE, and consider means it's an intervention that could be good and will need more of a discussion, and the GP evidence website can be helpful there, and it includes some evidence and number needed to treat and number needed to harm. So increasingly, people with heart failure are receiving iron therapy, and NICE have now included a recommendation on that. And they suggest it can be considered in people with reduced ejection fraction, and there's hematological parameters that are given. I find the transferrin saturation of less than 22% a useful parameter. The guideline group gave the rationale that IV iron can improve exercise tolerance and quality of life in the first year for people with heart failure with reduced ejection fraction and iron deficiency. Due to the risk of hypersensitivity reactions, IV iron products should be administered when there's appropriately trained staff and resuscitation facilities available. In terms of monitoring, NICE recommends 6-monthly monitoring at least for all people with heart failure, and that should include a clinical assessment, fluid status, functional capacity, medication review and renal function, and a reminder from the hypertension guideline that if someone's got postural symptoms, use the standing blood pressure. And also worth thinking about whether or not somebody has advanced heart failure, so somebody who has symptoms despite specialist optimized treatment, and it's not in the guidelines, but it's useful to also look for people who are having recurrent admissions. This is my summary of the guideline, and I've also put in brackets the recommendations which have been prioritised within the NICE quality standards. So moving on to the pneumonia guideline. Have a think about this lady. She's 72. She comes along. She's had temperatures, cough, phlegm, and breathlessness for the last couple of days. And she's got a temperature of 38.3, right lower zone crackles, a pulse of 98, and SATs of 95. And you think she might well have pneumonia. Past medical history, she's just got hypertension and a recent fall downstairs, with a fractured neck of femur, and she was discharged just over a week ago. No diabetes, no respiratory illness or heart failure. So the first question is this hospital-acquired pneumonia or community-acquired pneumonia? So hospital-acquired pneumonia is usually something that develops in somebody who's been in hospital for a couple of days. But the fact that this lady's had a recent hospital admission is important to take into account when assessing and managing her. She's at risk of more unusual or resistant organisms, and that might affect your antibiotic choice. In hospital, people with hospital-acquired pneumonia are advised to send sputum culture. So for someone with suspected community-acquired pneumonia, how do we assess the severity and whether or not to admit to hospital? So we'd be assessing for sepsis with the usual OBS, and then the recommendation is to do a CRB 65 score, so that's 1 point each for confusion, a respiratory rate of over 30, blood pressure less than 90, and age over 65. And then we need to use our clinical judgment guided by that CRB 65 score to decide how severe the pneumonia is, and a low severity pneumonia usually would equate to a CRB 65 score of 0. So we can use that severity assessment to guide our discussions about place of care. What about antibiotic course length? So as you know, people with cough, we often don't need an antibiotic, and we should really only be thinking about it in those people with higher risk of complications or who are systemically unwell. And that should be at a face-to-face assessment. And the recommended antibiotic course length there is 5 days, as you know. What about pneumonia? Does it change if it's community-acquired, hospital-acquired, or with age? People with community-acquired and hospital-acquired pneumonia, the recommendation is also for 5 days, but unless the microbiological results suggest a longer course is needed or they're not clinically stable. We might start seeing shorter courses coming out of hospital for children over 3 months and under 11 years with non-severe community-acquired pneumonia and without complications or underlying disease. And that's extended if the child's not clinically stable or improving as expected. So with these shorter course lengths, it's really important that parents are given the safety netting advice so that after starting treatment, symptoms should steadily improve, but that rate of improvement might vary. Some symptoms will persist after stopping the antibiotics. And for most children, the fever and difficulty breathing should resolve within 3 to 4 days, and the cough should gradually improve, but might carry on for up to 4 weeks after discharge, and does not usually require further review if the child is otherwise well. And then there's further health-seeking advice within the guideline. So that's been a very quick overview of those 2 guidelines. I hope they're helpful highlights. Do have a look at the full visual summaries and guideline details. And thank you very much for listening.